Believe all right, so that's recording has started. So once again, welcome to this month's session of the Zimbabwe Digital Health Society. Thank you for taking the time. In the past sessions, we had Dr. Chiurunge kind of unpack the whole spectrum of digital health, what's happening in Zimbabwe as well as the region. And then the last session, I was leading it. We were unpacking the Impilo National Electronic Health Record system, and as well as a digital platform behind it, to try and point out where people in the private sector could leverage, could see opportunities, how how the systems could link up, what this initiative by the government means for the rest of everyone who might be in the private sector. So today, we are progressing to the topic of the year, topic on everyone's mind, on everyone's tongue, that is AI, particularly looking at how AI then can be used in healthcare. One thing that we really try to do, or what we prioritize as the society, is to link with people that are actually involved on the ground, people that are actually doing it. Because it's so often to find online things that are maybe futuristic or things that are being done in other contexts. But we always want to then bring it home and show what is possible within Zimbabwe, what is possible within the African region, so that people can then get tangible insights, and we really then get to understand what's happening on the ground, and we realize that this is happening, and it is doable. It is certainly within our reach. So to just briefly introduce our speaker today, he is a renowned AI engineer, renowned data scientist, a renowned machine learning and AI researcher, who's also a senior lecturer, having taught many at the University of Technology, as well as the UZ. One of prominent figures in AI in Zimbabwe, someone with a vast experience, and not just in Zimbabwe, but working in other countries in the region, such as Kenya and Ethiopia. He might actually be joining us from Ethiopia. He'll get to confirm. He has experience not just in healthcare; it also extends to applying AI in finance, in agriculture. Someone who was actually mentioned as a key contributor to the recently published Zimbabwe national AI strategy from the 2026 to 2030. So the strategy for the country for the next 5 years. He got to contribute to that. So, ladies and gentlemen, help me welcome Dr. Panashe Chiurunge, who will then be taking us for this session. So he will present, and then after his presentation, we'll have ample time for questions and comments. Dr. Chiurunge, over to you, sir.
Hi, Doc. How are you doing?
Fantastic. Happy to have you here. So let me stop sharing so that I then allow you to get going on from your end.
Good to see you. How's Oxford?
Oxford is good. It's good. We were happy that it didn't destroy it when you were around, so it's still standing, and it will still stand for another 1,000 years.
All right, let me share my screen. Please confirm you can see my screen.
Yes, sir.
Yes, you can see.
Yeah. So thank you everyone for coming to attend this webinar. So today I've been tasked with the assignment of talking about AI implementation in healthcare, and my perspective is not from a theoretical one. It's actually from all the experiences that we've had with Dr. Marlon-Ralph, the experiences that I've had in Kenya and also in Zimbabwe. So the agenda of this presentation is we're going to look at the challenges that we face, and we're going to look at the digital health footprint in Zimbabwe. We'll look at how AI is used in healthcare, the global AI healthcare revolution, why AI is Zimbabwe's game changer, and then we'll look at some of the work that we're doing with Dr. Nyakabau and the Minister of Health and UNICEF, and some of the examples of the models that we've created. So the challenges that we face is not only unique to Zimbabwe. So if we look at, for example, the doctor to patient ratio in Zimbabwe, for Zimbabwe, it's 1.7 for every 1,000 people. Yet the WHO, the minimum recommended is 100 per every 100,000. And then if we look at some of the patient to doctor ratios are actually much worse in the under-resourced areas and the rural areas. It is as worse as 1 in every 12,000. And then if you look at the healthcare spending per capita for Zimbabwe, it's only $20 per person annually. That's the healthcare spending per capita for Zimbabwe. And the WHO minimum required or level is $86. So this is the Zimbabwe's healthcare reality. So if we look at the digital footprint that we have, Zimbabwe has got a mobile penetration rate which is more than 100%. So a lot of people have got at least one device or more than one device. So the mobile penetration rate is 102%. The internet penetration rate is 81%. And already Zimbabwe has got Impilo, AHR, which has been implemented in 1,179 healthcare facilities, which are all digitally connected. And also Zimbabwe is considered to be a regional leadership in digital health in the SADC region. So if we look at some of the use cases of how AI is used in healthcare, AI is used in clinical decision support, where AI assists in diagnosis, treatment, and drug interaction alerts. And then also AI is used in predictive analytics, where AI forecasts outbreaks, predicts patient deterioration, and optimizes resource allocation. And most of the usage of AI is actually in administrative automation, in EHR records, where AI automates clinical documentation, appointment scheduling, and medical billing. And then for diagnostic imaging, AI analyzes X-rays and then screens, and it can detect cancer, detect retinopathy, and so on. I've left one use case, which is in drug discovery, because that's not really popular in the African setting and context. So if we look at the global AI healthcare revolution, the market reality that we have is currently, if we look at 2024, $32.3 billion was spent on health on AI in healthcare, and that is projected to grow to 208 billion by 2027. So we're looking at a projected growth of more than 524% within a period of 2 years. And then 22% of healthcare organizations implemented AI 22% of healthcare organizations implemented AI, which is a 7 times increase from 2024. And then in the United States, we have 430,000 US physicians using AI on a daily basis, which is 40% of all US doctors. And then the leading applications that are used in AI are mainly administrative documentation. So 6% of the AI is used in EHR records and in administrative documentation. And then we've got 10% is 20% is for clinical decision support, and 10% in predictive analytics for any form of predictive analytics in healthcare. And then about 5% is spent in drug discovery. So if we look at the adoption explosion from 2023 to 2024 in terms of AI usage in healthcare, it grew by 38%. Then from 2024 to 2025, up to currently now, it has grown by 66%. And 85% of healthcare leaders are already exploring the application of generative AI in healthcare. So if we look at this global AI healthcare revolution, it's already happening. It's not the future. It's already happening right now. So the question now is, how does Zimbabwe participate in this AI healthcare revolution? How does Zimbabwe adopt some of these technologies to leapfrog and implement AI in healthcare? So why is AI a game changer for Zimbabwe? Why is AI a game changer for Zimbabwe? The first point is workforce multiplication. Currently, we looked at the Zimbabwean patient to doctor ratio. Zimbabwe needs 64,000 medical professionals or practitioners by 2028. So it's impossible to train 64,000 workers by 2028. It's literally impossible. So if we look at all our medical schools and all our schools which produce nurses, they don't produce more than 3,000 medical practitioners every year. So if we look at 2028, we're literally almost at the end of the year. So within 2 years, it's not possible to produce 64,000 workers. So AI augments existing doctors' capacity. So if we look at, for example, the administrative automation that AI can bring, it will free up 6 or more hours per week per clinician, giving them time to spend on other areas of work. So if we look at the AI triage, it can prioritize cases by severity. And the second point is you can now have a specialist in every district hospital, because all the under-resourced areas, the doctor-to-patient ratio is far much worse than the urban areas. So AI will bring specialists level diagnostic support to rural areas. And then you can have the technology doing diabetic retinopathy screening, TB detection via imaging. We can have cancer screening like we have at the moment in Kenya, where cervical selfies have about 100,000 images per day for screening cervical cancer. And then it can also be applied in genetic analysis for African populations. The third point is the predictive power of disease surveillance. So Africa reports 160 plus disease outbreaks annually. So AI can predict malaria outbreaks with more than 80% accuracy. We'll look at the malaria outbreak prediction model that we created for Mashonaland East Marondera. And the response time can be reduced by as much as 85%. So if we look at the COVID-19 cases, we will see that digital systems enabled QR vaccination cards and quarantine and tracking in almost a near real time. So this is part of the power of disease surveillance that AI can bring. And then the resource optimization. So for example, in Kenya pilot project, which I was involved in, there was a 50% improvement in medical supply availability. And then the predictive analytics for bed management. In Zimbabwe right now, we've got a serious issues in the hospitals with bed availability. And then AI can also bring resource chain optimization to prevent stockouts. So an ideal use case for NatFarm. Workforce deployment based on predicted demand. So when there's a huge demand for medical health professionals because there's a particular outbreak, AI can predict that particular demand before it happens. So we've got a potential of a 15% health cost saving when it comes to application of AI. So AI is really a game changer for Zimbabwe because we are not able to create the resources that we need, and the only thing that can close that resource gap is actually AI. So AI is actually a serious game changer for Zimbabwe. So let's have a look at the Zimbabwe implementation roadmap in the project that we are involved in at the moment. So the project chief program coordinator, of course, is our Dr. Ralph Nyakabau, and then we've got Dr. Zijo from the Ministry of Health and MLHCC, Ministry of Health and Childcare, and then we have Dr. Gongora, and then there's myself, the Chief AI Scientist, and then we have Leslie Rora, who's the Chief Data Scientist and the Data Protection Officer. And then we've got Tapio Mungani, who's the AI Chief Engineer, and then we also have Nores Hammer from UNICEF, who are part of our sponsors on the program. And then if we look at our AI architecture, so what we've done is of which we'll show you just now, we are integrating data sources from various data sources, and those data sources, we're aggregating them into one repository where we'll be able to do machine learning and AI for decision support systems. And that AI is integrated to AI agents, and the models that are created have got what we call a model registry or versioning system, where we've got multiple models running at the same time. And the model that has got the best accuracy is the one that is utilized within the system as part of the version control. And the agentic framework, the AI agentic framework that we've created is integrated to the National Health Policy Framework, is integrated to all the Zimbabwe, a lot of medical research papers. So what we are trying to achieve is we're trying to create an AI ecosystem which does not hallucinate, which because we're dealing with healthcare, we have to create an AI which only responds to correct questions and is able to respond with 100% level of accuracy. So we've created an agentic framework that completely removes hallucinations, and that is then integrated to to all the frameworks that we have in Zimbabwe. So then that allows decision support for any system that can be plugged into this AI platform. So the data sources that we're going to be integrating with. So Zimbabwe currently has got DHIS2 from the Ministry of Health. So all the data, all the health facility data, the disease surveillance data, all the different programs that happen in Zimbabwe are hosted in DHIS2. Then we have got the medical commodities data of all the different commodities which are dispensed by NatFarm. And then we've got the ZimStat data, which has got all the different statistical data from population demographics, economic indicators, and so on. And then we also have GMB, the Grain Marketing Board, which is our food security silos, where we've got our grain production and food security warehouses. And then Impilo EHR application, our patient records and our clinical data. Then we also have the meteorological department, where we've got all of the different weather data, because, for example, malaria only happens in particular seasons, and weather is a big component for malaria. So the meteorological department is a key data source. Then we also have TRMB, which is our tobacco auction flows and so on, so that we can get all the different economic activities that are happening at the different auction floors. And then we also have geospatial data, which we're going to integrate from the Zimbabwe Space Agency. So these are all the data sources that we're integrating. And these data sources that we are integrating into one single repository, what we're going to do is this data is going to be anonymized, because we are not interested in any personal information. What we're interested in is creating a huge data repository that will allow us to create the AI algorithms and train the AI algorithms. So based on these data sources, at the moment, the data pipeline consists of data collection, and we have to cleanse the data, we have to anonymize the data, and then we of course explore the data, and then anyone who then needs the data to create their own machine learning or AI algorithm can create their own variables or feature, or what we call feature engineering, and then they can train their own models in either their own infrastructure, because this data is hosted at the Zimbabwe Center for High Performance Computing. This is where all the models are going to be deployed. And we also have created a model evaluation framework, which the different medical practitioners can actually evaluate the performance of the models that they're using. So in terms of the implementation roadmap, so the phase one was about establishing. So we started this program in December 2023. We started this implementation in December 2023. So that was phase one. So phase one was about establishing a governance framework, and then to set up the infrastructure in the High Performance Computing Center, and then get the approvals from the Ministry of Health to be able to integrate all these different data sources. And then based on those data sources, we're now able to create more AI model prototypes that we can then test. So we are actually now in phase two, where we are now where we have to now get more resources in terms of core infrastructure, where we need to complete the data integration. So the idea is instead of going to ZimStats, Ministry of Health, or Med Department with a USB stick and getting their data, we are actually integrating to their system. So their system then push data into our repository, which is then aggregated on a monthly basis. And then part of that, we've been allocated a few GPUs by the Zimbabwe Center for High Performance Computing. We've been allocated 4 GPUs that we are testing some of these models. So that's phase 2 of the roadmap. And then phase 3 is about creating then advanced capabilities where we will then integrate the AI agentic framework, and then we'll refine the models based on the use cases that would have implemented in the pilot in the phase 2 based on the feedback that we'll have from the medical practitioners. And then phase 3 is about scaling and optimization. We want to be able to scale so that every medical practitioner in Zimbabwe is able to utilize the platform. And then phase 5 is about evolution and expansion, where we implement and scale the infrastructure to continuously improve the platform and expand the health care use cases. So currently, UNICEF, their key use case, which is was one of the motivations for creating this platform, was for primary healthcare. So the idea of this platform is to have it open so that every medical practitioner can utilize the data, create their own use case on this platform. So the use case for UNICEF was primary healthcare, where they are of course concerned about maternal, newborn, and child health. They're concerned about immunization campaigns, public health emergencies. So every NGO, every key stakeholder will have their own particular use case that they will utilize this data and platform for. So here's an example of one of the models that we created. So we created a malaria prediction model. So the malaria prediction model was based on the data that we took from Marendera Hospital, which was for the Marsh, Shonaland East, excluding Mutare. So that data goes as far as Headlands, I believe. So we created, so this data was collected for the past 20 years. So what this model is able to do is able to accurately predict malaria based on a number of variable or features that we'll look at just now. And we created what we call a deep neural network. And this deep neural network using a technique called XNet. So we created a type of activation function which for medical precision accuracy purposes, which allows us to have a high accuracy, especially for medical application, which gave us an accuracy rate of 91%, and it's got an early detection rate of 85%. So this model was created using TensorFlow and is hosted on TensorFlow Serving and NVIDIA Triton, and is actually hosted right now in the High Performance Computing Center. So based on the results that came out of this model, it's actually able to tell you what are the key importance features or feature importance for malaria prediction. So temperature, heart rate, PCV, weight, respiratory rate, whether they vomited or not, abdominal pain, fever, and so on. So these are actually the ranking of the importance of the variables in terms of predicting malaria in Mashonaland East or in Marondera. So what we're then able to do is based on this model, it will actually look at the clinical measurement impact to say what is the temperature distribution pattern, what is the heart rate variability analysis, what is the PVC level significance, and what is the respiratory rate pattern. So we then were able to, the model was then able to create a symptom analysis where you've got for those who are malaria positive and for those who are malaria negative based on each variable or indicator to say for those who have vomited, what is the comparison of each feature or variable. So for those who vomited, what is the comparison of the symptoms for vomited fever, headache, weakness, abdominal pain, and also the key diagnostic indicators and the pattern recognition insights. So what the model, what the agentic AI framework is now able to do is it's now able to create a risk assessment framework. So it will automatically generate a risk assessment framework. So this is the risk assessment framework that was generated from by that model. So it was not generated by us, but it was actually generated by the AI model. So where, for example, vomiting based on the malaria symptoms, it indicates gastrointestinal distress, fever suggests inflammatory response, headache represents neurological symptoms, and so on and so on. So the risk assessment framework was actually generated by the AI. So what we found from based on that risk assessment framework for the people who were diagnosed with malaria or people who had malaria, the abdominal pain, there was an increase of 4.26 times increase in risk in terms of abdominal pain. And then appetite loss, 1.94 increased risk, and headache, 1.6 increased risk, and fever, 1.3 times increased risk. So what the model was able to then do is actually then create the key performance indicators that are supported in terms of the clinical KPIs, the community KPIs, and the outcome KPIs. So the clinical APIs, for example, temperature monitoring, heart rate assessment, PCV testing for diagnostic accuracy. And then the community indicators are, for example, education reach to say you need mosquito nets and health worker coverage, and then some of the outcome KPIs where you're now looking at how do we reduce some of the cases and have a treatment effectiveness. So the diagram that you actually see was actually created by the agentic AI framework that we created. Because of time, I will skip some of these models that were created by the AI algorithm based on the Marondera data. So, for example, it was able to create a monitoring and evaluation framework based on this data, and then it was also able to create a decision support a system which is then integrated into the national digital health systems. And then it was also able to create the ML integration strategy, how the model is integrated into other various support systems. And then it also created the malaria reduction strategy for Marondera. Because of running out of time, I'll take any questions.
Thank you very much, Dr. Chiurunge. Yes, as you said, is inviting questions, so you can raise your hand. You can type a question in the chat there if you want us to read read your question out for you. You can make use of those facilities. But just to say, I appreciate sessions like this, platforms like the Zimbabwe Digital Society that bring people from different backgrounds together, people that are in the health sector or in the medical sector, as well as people that are non-medical in the and are in the technology sector. And then we then have language bouncing off each other. I think that's what's required for us to go forward. We have people like Dr. Chiurunge now having to understand about symptoms, about gastrointestinal, what is it, sensitivity, and so forth. And then we are getting to learn about agentic AI and GPUs and on all those things. So it's not about necessarily all of us becoming experts, but it's about us having an understanding and an appreciation of each other's field, and then that's where we can then come up with ideas and then cooperate and collaborate and push the digital transformation of the country forward. And as you were presenting, Doc, I was just marveling to myself that I kind of know people that are in all those use cases. You mentioned diabetic retinopathy, and there's an NGO in Masvingo involved in that. You mentioned the cervical selfies. There was one local doctor who presented at the Zimbabwe Medical Association Congress, I think last year. Yes, presenting on how they're using AI to help with evaluation of cervical images for cancer, for cervical cancer screening, and people involved in TB detection. All those applications. Even a very good friend of ours, a pharmacist who developed an AI model for asthma diagnosis. So a lot is happening. Maybe as others are still thinking about their questions, let me take advantage and be the first one to ask. I'm going to ask a question in relation to the Zim strategy, the Zim AI strategy that you were part of. So from your understanding, Dr. Chiurunge, what level of optimism do you have, or level of belief and hope do you have in that strategy in making a contribution in getting us where we need to go? What are your sentiments, things that we might not necessarily see written in the document, but you having been involved in the drafting process? What are your sentiments regarding the Zim AI strategy?
So the biggest gain from this strategy is when you've got the president of the country fully behind AI implementation. Similarly, like what you have with the U.S. President Donald Trump with the Stargate project, fully supporting all the big tech companies in terms of infrastructure. So we have that support coming from the president's office as part of the strategy. So we've had cabinet approval where the whole entire cabinet has approved that AI strategy. So that might not be written in within the AI strategy, but we actually have cabinet approval for everything within the AI strategy, and also the resourcing that will be required to implement AI in Zimbabwe. It has to be part of the budget coming from the Minister of Finance. So that was part of the biggest gain from this participation in the AI strategy.
Indeed, and leadership and governance is critical as an enabler. And when the dollars follow what our mouths speak, then that's even more important. So we have a question there in the comments. I'll read it on behalf of Lisbon Charai. It says, thank you for the presentation. Wanted to find out what are the recommendations for someone who might want to venture into applying CNNs in the field of healthcare. And in terms of access to data and computing power required, will this make it any easier? So it's talking about neural networks there. So yeah, Doc, over to you.
Yeah, so the use case is probably some imaging, right, where they're using when you want to use convolutional neural network for some kind of classification. So the data sources that we are collecting at the moment or aggregating does include some images, but at this stage, the limitation that we have obviously is storage. So for us to complete this exercise, we need at least 3 petabytes of data to be able to create this repository. The computational capability as well. So if you have huge images, a large data set of images, you need then to use GPUs. There's no way out of it to be able to create your model. Because CNNs are actually very resource hungry in terms of computational resources. So you have to have the computational resources and also the data, depending on what kind of classification that you're trying to do with convolutional neural networks. Yeah. So if you need any help, we're more than happy to help. But the High Performance Computing Center, you can actually run your algorithms there. They will allocate GPUs. There's not a lot of GPUs right now. The whole of Zimbabwe has only 40 GPUs. So you will have to submit your use case, and they'll be able to allocate maybe a maximum of 4 NVIDIA V100s. That's what they have. I hope that answers your question.
Thank you for the response. Nyasha, I do see your hand, and Pascal, I do see your hand.
It's Pascal. Yeah. I just wanted to know if this scenario can be implemented in basically in some of the African country, particularly West Africa.
Yeah. Hi, Pascal. So Pascal is from Cote d'Ivoire. So he signed in from Cote d'Ivoire, Doc.
Oh, that's amazing. That's amazing.
Yeah.
Welcome. Bienvenue.
Right. Merci beaucoup.
Go ahead, Doc.
Yeah, absolutely. So it's just about the data and the infrastructure. We can actually do the same thing in any African country. That's the beauty part about the AI use cases that we've implemented. And of course, the game changer that I talked about earlier does not only apply to Zimbabwe, it also applies to majority of the African countries because of our under-resourcing when it comes to medical infrastructure, when it comes to the human resources. Our doctor-to-patient ratio for Zimbabwe, as I said earlier, is 1.7 for every 100,000 patients. I'm not sure what that is like for Cote d'Ivoire, but it's about within the same range. None of the African countries actually meet the requirement of having 100 doctors for every 100,000 patients.
Yeah. Thank you, Dr. Panashe.
All right. Nyasha Stole, I see your hand. Please go ahead and unmute and ask your question.
Thank you very much, Dr. Nyakabau and team. I saw one of the slides where you're talking about information sources. I wanted to check to what extent you have managed to handle. I understand majority of our data is it had some red boxes. This one. So I understand majority of our data is in manual form somewhere, and last time I was still involved, even this Impilo thing had a significant portion of it being done by data encoders instead of direct encoding. So what are you doing to like clean that before you put it, as I understand that, garbage in is garbage out? Then to what extent have you managed to convince probably the Ministry of Home Affairs, the guys who handle the our fingerprints and so forth, to sort of like allow integration into this advanced model? The last time I know they would say security, but it would be very important for us to have a contextualized data in our own context. And lastly, are there any plans probably to loop this into the training institutions to start appreciating the role of AI? I know the academicians still penalize heavily the students for using AI, but they also use AI to check for plagiarism. Like, what are we doing to change the attitude, especially at training institutions, to accommodate this? Thank you.
Yeah, so thank you for the question. So in terms of the data process of cleansing the data and matching records and aggregating the data. So the data warehouse or data lake that we're creating, part of the process is to cleanse the data because, as you rightly said, garbage in, garbage out. So it's part of the data, what we're calling the ETL process or the data pipeline process. So all data has to be correct and has to be valid data for it to be used in AI training for healthcare. And your question about integrating data from Home Affairs. So what we've done is we've made a request to, for example, to NatFarm through the Ministry of Health, who's responsible for this project. So NatFarm is responsible for medical commodities. That approval hasn't come yet. So the approval that we have at the moment is for DHIS2, Zimstat, GMB, Impilo, the Met Department, TIMB, and the geospatial data from ZINSA, the space agency. So we will be adding this data on a case-by-case basis as we are given the permission to integrate and aggregate the data. So this is why we've got, a data protection officer, Leslie Sirora, on board, and also our data, who's also our data scientist, to make sure that as part of this exercise, we are not taking any personal information records. What we're interested in is data for training AI and not personalizing any information. So yes, it's in the pipeline. So we haven't got that permission yet. And then in terms of the universities, so this data will be made publicly available. For example, for medical students who want to create AI algorithms based on any research that they're doing. So yes, this data will be made available to all the key stakeholders, including the different medical faculties in Zimbabwe.
Yeah, thank you, Dr. Chiurunge. Maybe just to add in relation to the project that was mentioned, the one that's on the screen, that what we're doing with the Ministry of Health, it's important to also reiterate that the project is fully owned by government, fully owned by the ministry. UNICEF, as well as people like myself and Dr. Chiurunge, are coming in only as technical partners. However, everything is owned by the government. So like you said, we're starting with data sources that we could access, some data sources that within the ministry themselves and utilizing those. And I think some of the questions in terms of linking other sources from Home Affairs, from maybe something that we hope is addressed in the overall AI strategy, that we can then have some form of DPI set up at government level that then integrates sources from various departments. So we're starting with what we could, and then as it grow, we keep on getting the necessary permissions. But it's easier because it's something that is within government, owned by government. It's not a private sector run thing. We have questions online. There's a question from Mr. Zaniweza, who is asking about the use of local languages in models. I think it's a very pertinent question. Actually, the first time I met you, Doc, you were talking about use of local languages in our LLMs, and so maybe you can respond to this one.
So what we've done is we've done some work in terms of so this is the data pipeline. So in terms of the let me go back. What we've done is we've integrated Shona and Ndebele. So those are the key languages in Zimbabwe. So of course, English, Shona, and Ndebele are the key. So trying to then, for example, do a language like Shindao, where you don't have enough data to be able to train the model, is not realistic. So what we can do is only English, Shona, and Ndebele. The others is a nice to have, but we don't have sufficient data to be able to train the models on those languages. It's just an issue of lack of data, and also, of course, lack of enough infrastructure to be able to. So imagine you have to almost, when you're creating, for these under-resourced languages, that capability, you now have Shona capability, English, and so on. What you're actually then doing is you're increasing the size of the model. And when you increase the size of the model, it means the scale of your infrastructure has to grow as well. So because of that limitation, at the moment, what we've taken into consideration is the key languages that are spoken in Zimbabwe, which is English, Shona, and Ndebele.
All right, thank you, Doc. Then there's a question from Haile Mariam Amare, who asks how this work is interrelated with other sectoral AI leveraging strategies in the holistic national development ecosystem. So I guess maybe this is pointing towards the AI strategy and then showing how things are linked together. Maybe you can add more on that, Doc.
Yeah, so in terms of our national AI strategy, so what is important for any African nation is to work on AI projects that move the needle, right? So creating an AI agent that will book your hotel and book your flights is not something that will move the needle. It might be a good use case for a particular corporate, but in terms of for the nation of Zimbabwe, it's not going to move the needle. So what we've looked at is to say, in terms of the Zimbabwe GDP, what sectors can we transform that will significantly lead to our GDP growing, right? So one key sector is health, right? By growing the health sector, we can actually grow our GDP from about 40, current now about 44 billion to about 80 billion within a space of 4 years by 2030. So the aspiration of and the vision of the president to have a middle income nation by 2030 can only be achieved by us having access to good healthcare. And that access to good healthcare can only come from applying AI because of the resource issues that I said earlier. In terms of the doctor-to-patient ratio, infrastructure, acquisition, and so on. Yeah, so it ties into every strategy. So the next thing is agriculture. Agriculture is still a big component of every country in Africa. So those key sectors, if we implement AI to accelerate agriculture and healthcare, Zimbabwe can actually be $100 billion economy by 2030.
Billion with a B.
Yeah.
Yeah, that's good, and yeah, we all hope to see it happen. We all hope to be a part of making that that possible. So yeah, quite a lot of hope and expectation around the AI strategy. Yeah, considering time, Doc, we really want to thank you for taking the time to come and take us through. I know you have lots of other work that you have researched on in terms of applying machine learning in health, other models that are there. So maybe you can then share us a link to your publications that we can then share with the rest of everyone else, maybe via our LinkedIn page, so that people can get more acquainted with the work that you have done, so that people get an understanding of how it is that they could leverage machine learning or AI in health. So once again, thank you so much, Dr. Panashe Chiurunge. It was quite a great session.
Thank you, Doc. Then, so thank you everyone for your participation.
Indeed. So everyone, we encourage you to keep on following the Zimbabwe Digital Health Society. Follow us on our LinkedIn page. We're going to be having a mailing list and just ensuring that we have more events. In terms of what to look forward in the next sessions, very interesting speakers that we have lined up. We know we have Zimbabweans doing amazing things in high places. So some of them are willing to spend some time to just show us what people are doing out there with their resources, for us to then also get an understanding of what we can apply at home, as well as looking at having a particular session on the business of telemedicine. There are a lot of telehealth or telemedicine businesses coming up, naturally so. So it's good to get a dive, do a deep dive onto this. There was even one launch this week. So in the coming sessions, we hope to then bring people that are involved in this area. We then get to discuss it as a community of practice. So once again, thank you for taking the time. You can find this video on our LinkedIn page, and we look forward to having you in our future sessions. Thank you, everyone. Have a good day and good evening.